Hello, and thank you for joining us for Mayo Clinic's Facebook Live. My name is Hector Michelena, and I am a cardiologist. I specialize in diseases of the aorta and also in heart valve diseases. And today we're going to talk about thoracic aortic aneurysms and surgical management of these. We will be taking your questions throughout the broadcast to make sure that we can answer, so post them, please. And with me today are two good friends who are highly esteemed surgeons and specialize in the repair of thoracic aortic aneurysms, and they are Doctors Gabor Bagameri and Dr. Alberto Pochettino. Dr. Bagameri and Pochettino, thank you very much for joining me today. And we're going to start off our discussion a little bit by talking about thoracic aortic aneurysm. You see, in medicine, we give weird names to things to look that were very bright, but in reality, it's all very simple. So what we mean by thoracic aortic aneurysms is dilatation of the aorta within the chest. So if we look at the little diagram that we have, you will see that there's a heart there, and coming out of that heart is a red big hose, which is called the aorta. And this aorta is the biggest blood vessel that we have, and it takes blood to the body. And you can see that at the base of that aorta that we call the root, there are two little coronary arteries coming out. These are the vessels that give blood to the heart itself. So if we go to the diagram, you will see, and once again, we're going to be talking about this big vessel called the aorta and its origin within the heart, and then how it goes up and into the chest and then makes a turn and goes down, but only the part that belongs to the chest. As you can see in that diagram, there is the root. The root is the beginning of the aorta and has the aortic valve. If we go up, you can see that then there is the ascending aorta, and then the aorta takes a turn and it forms the aortic arch, which gives vessels to the head and the arms. And then after that, you can see that it turns all the way around and down, going towards the belly. And that is the part that we call the descending thoracic aorta. Now, how common is this disease of dilatation of the thoracic aorta? Because the word aneurysm, so that you know, means dilatation, means that something is getting bigger. And these dilatations of the aorta in the chest affect about 7 per 100,000 people. And I give you the comparison to coronary artery disease in the US. So you can see the number is much bigger than 7 per 100,000. And then if we look at the complications, the potential complications of having one of these aneurysms in the chest, you can see that the complications of having, for example, an aortic dissection, and we will talk about that, is about 2 in 100,000 people. Compare that to 300 per 100,000 people that have heart attacks. So the bottom line is that this disease is not very common. I don't know if my colleagues have a comment regarding that.
While it's not very common, it is potentially very dangerous. The number that was shown from 7 to 100,000 to 2 to 100,000 means that when something goes awry in an aortic aneurysm, giving rise to a dissection, it's bad news. Yeah. And it could be lethal. Of course, a heart attack can also do that, but the risk having coronary disease of developing heart attack, relatively speaking, is much lower.
Yeah, yeah. Okay. So this is a disease that is not very common, but it can potentially have dangerous consequences. And this is important to note. Now, as everything in life comes in different flavors and different size, so there are patterns or types of dilatation or aneurysm of this aorta within the chest. And you can see to your far left that there's a normal aorta. You see that it looks basically like a hose. and the size is kind of homogeneous. You can see the root, which is the base of it, and you see two little vessels coming out of there, which are the coronary arteries that give blood to the heart. And then you start going up, as we showed before, that's the ascending aorta, to the arch, and then it turns around and starts going down. And then it goes down through the chest and then into the belly. But if we look at the next one to your right, you will see that there is clearly an aneurysm or dilatation of the ascending aorta that does not affect the base of it. So it does not affect the root. This we see commonly. Then if we go to your next right, you can see another type where it is that root, that base of the aorta that is very big, as you can see, in comparison to the rest of the aorta. And then finally, of course, we can have a mix of patterns, as you can see on your far right, where you have dilatation or aneurysm or enlargement of the root and also the ascending aorta. And then there are other cases that I am not showing here where the arch can be big, and also other cases where the descending portion of the aorta can be big. But to give you an idea of how we look at this disease, we look at it, at these thoracic aortic aneurysms, a little bit in four groups that you see over there. There are two in red or orange and two in white. The first group is the syndromic one, and that represents less than 5% of thoracic aortic aneurysms. These are patients that usually have syndromes, and what we mean by syndromes in our profession is patients that have certain characteristics to their face, to their body, that you can tell that likely they have a syndrome. And these syndromes have been discovered to have a genetic basis, and there are genetic tests for these. The second one, as you can see there, is a bicuspid aortic valve. 1 to 2% of the general population have a bicuspid aortic valve. What do we mean by this? The aortic valve is that valve that is within the root of the aorta, and that aortic valve usually has 3 little doors, 3 cusps. People that have a bicuspid aortic valve instead of a tricuspid aortic valve have only 2 little flaps. And that is associated with aortic aneurysms in about 30%. Then we have the familial form. The familial form, usually you will hear a patient that tells you that their father or their grandfather or their brother had a problem with dilatation of the aorta in the chest. So it runs in families, and we can check a specific battery of genetic tests to identify what gene is involved in these familial cases. Unfortunately, the yield of those genetic tests, in other words, how many times we find actually a genetic problem, is about 20 to 30%, so it's not very high. The good thing about doing genetic testing is that if I find an abnormal gene in an individual, then the only thing that needs to be checked in their offspring or their siblings is that gene. And if they don't have that gene, they don't have the problem. And then finally, which is the most common form, as you can see there, 80%, is the sporadic one, which affects about 80%, and it's usually seen in patients above the age of 60. And I have 2 examples there of the familial form. I have the example of John Ritter, a famous American actor that had a familial aortic aneurysm condition and unfortunately died from an acute complication of it. And very interestingly, I have as an example of sporadic, Dr. DeBakey, who actually had an acute complication, an acute aortic dissection, which he recognized himself in his own home and called 911 and had people take care of it. Now, it's very interesting because Dr. DeBakey was one of the pioneers in the surgery for thoracic aortic aneurysms. So we know, and now that we are now in topic, I wish to start asking some important questions to my colleagues. And the first thing I want to ask, perhaps, Dr. Pochettino, is what does a person feel when they have an aneurysm?
So it's a very good question. The answer is most of the time they don't feel anything. Most aneurysms are what we call asymptomatic. The growth of the aorta, unless it presses on the structures around it, is unlikely to cause any symptoms. Now, the only exception, which are rare, if the aneurysm is involved with inflammation, there is a very rare inflammatory cause of aneurysm, and those can have some low-grade chest pain or chest pressure. Or when an aneurysm is in location where it can press some specific structures. One, again, this is very rare. One of the examples in the arch, if it presses on one of the nerves that goes around the arch called the recurrent laryngeal nerve, you can have some voice changes where your voice is not normal anymore. Those are by far the minority. The rule for aneurysm is that they are asymptomatic, and therefore finding them before symptoms is very important. You know, the adage of the first symptom is often the last symptom. Meaning if you present with chest and back pain, you're probably having a complication of the aneurysm rather than the aneurysm itself. So screening and figuring it out ahead of time is key.
Okay. And I would like to ask Dr. Bagameri then, how do we diagnose? How do we make the diagnosis of a thoracic aortic aneurysm?
As Dr. Pochettino mentioned, this aortic aneurysm most commonly asymptomatic. So most commonly you get incidental finding on routine imaging studies, unrelated medical cause. Sometimes there is no obvious physical sign or examination, and you can diagnose thoracic aortic aneurysm. Sometimes in the abdominal aorta, you can feel the pulsating mass if it's big enough, but because of the chest cavity, it's very hard to diagnose. Sometimes you can pick up on routine chest X-ray. You can see that the contour of the heart is enlarged and can raise a suspicion that you might have, but it's hard to diagnose for sure this is a thoracic aortic aneurysm. The two imaging modalities which are very useful diagnosing is ultrasound, which you call echocardiogram, and it's specifically for the heart. It can be transthoracic when the probe is outside on the chest, or sometimes can be transesophageal when they have to put the probe through the foot pipe, or CT, computer tomography CAT scan. I don't know, maybe we have some images to pull up.
Yes, we actually have an example of an echocardiogram so that you can see up there. This is a transesophageal echocardiogram, and you can see the images and how we measure that tube. On the first one, on the first one on your upper left, the tube is cut transversally. And then on the other one, it's on the next one to the right, it's cut longitudinally. And then you see how we measure the size of that aorta. And then the two panels below show you how we measure the base of that aorta, or the root. And if we show the CAT scan image that we have, you see the top one is basically how that thoracic aorta looks. And this is a patient who has a lot of dilatation of the root. As you can see, it's a big root. And you see that that is the aorta there. For those tests with the CAT scan, we generally use contrast.
Hector, I just would like to point out the importance how you may measure the size of the aneurysm. It's very important that the measurement should be perpendicular to the flow of the axis of the aorta, because sometimes the aorta is a tortuous structure. And there is also, say, significant variability between even the same examiner can measure differently. So there could be a couple of millimeters. So usually we don't say it's significant unless there is more than 5 millimeters.
So I think it's fair to say that usually the first pickup of an aneurysm is through echocardiography, or by a familial suspicion that you send the patient for an echocardiogram to take a look at their aorta. But when we want to do very, very exact measurements, then we go to other imaging modalities that can be a little more accurate than echocardiogram, which are computer tomography and magnetic resonance. should family members be screened? And how do we do that? So maybe we can put our little image of the 4 groups. And we spoke a little bit about this already. Generally speaking, in the syndromic ones, you kind of recognize that the patient's appearance is not normal, and that gives you a clue into what syndrome they may have. The most common of these, or the most common that is mentioned that people know, is Marfan syndrome, for example. And then you would look at their aorta, because we know that Marfan syndrome comes with thoracic aortic aneurysms. In bicuspid aortic valve, if you have a bicuspid aortic valve, it is important that your offspring and siblings be checked for a bicuspid aortic valve, because it may run in families, and there is a 10 to 15% chance of transmission of a bicuspid aortic valve to your offspring. And then again, bicuspid aortic valve is associated with about 30% chance of developing enlargement or aneurysm of the thoracic aorta. Once again, in the familial form, when you have a patient that has family members that have this disease, there is a genetic battery of tests of all the genes that have been discovered that we can test on them. And again, it's not very high yield, but it can be very useful. And finally, for the sporadic one, I would like perhaps Dr. Pochettino to tell us if you have a patient who is 80 years old and has a history of smoking and high blood pressure and comes with a big aneurysm, would you check their family?
I mean, in general, if what we would consider acquired aortic aneurysm as identifiable risk factors, again, the one you mentioned, high blood pressure, smoking, then I don't think it's necessarily useful to check family members. If we have an older individual, let's say 60 years old, to make things a little bit more gray, that has an aortic aneurysm but has no hypertension and has never smoked, while it falls into the category of sporadic, we cannot completely exclude some familial component. And therefore, again, it may have to be individualized, but consideration for screening should be given. And again, screening in general means echocardiogram.
And that goes very nice with the question that we have from the audience, which says, I'm the only person in my family to have a thoracic aortic aneurysm. What could cause this? I am otherwise fit and healthy person. And I think it is important in that case to be evaluated by somebody who has expertise in aortic aneurysms, and that could potentially require for you to have genetic testing and for you to have your family members evaluated as well to see if this is a familial cause or not. I don't know if you have any comments regarding that question that we have from the audience.
That is not an unusual situation. We deal with patients that have no family members, no one else has enlarged aorta. And the reality is, while we have identifiable causes for aneurysm, a lot of patients we just do not find a clear-cut smoking gun, as it were. So they may have no genetic identifiable, they may have nothing in the family, the blood pressure is normal. So there are plenty of people where we just don't know why. And just because we don't know why doesn't mean that we should not pay attention, and we certainly should. And that then gets to how big is too big and when should we start talking about.
So Dr. Bagameri, how big is too big? What is the importance of size in this business?
This is a very good and important question. To get to this point, I think we have to answer what's the normal size of the aorta, and it's probably not easy to answer. We know that the aorta is growing. As we're getting older, it's very slowly getting bigger and bigger. We can now, because the CAT scan, due to the CAT scan and MRI being very easily available, we know that the normal size aorta for a middle-aged person is probably around 3.2 centimeter. Nobody probably should have an aorta bigger than 4 centimeter. As it gets bigger, I always tell my patient in the clinic, imagine a balloon. As the more air you put in the balloon, the bigger it gets very thinner, and at some point it's going to pop. The question is, what's the limit? Where is that when the aorta gets too high? It's a little bit different. On average, we can say that the most commonly used number is 5.5 centimeter on the sporadic aortic aneurysm. But it's
So if
also
you have a sporadic aortic aneurysm of the thoracic aorta, 5.5 centimeters is considered a limit. A limit to what?
for intervene surgical threshold on average. Obviously, it's important the age, the gender, and also the size of the patient, the height, the
Yes.
weight, and the body surface area. It's not the same, and like a 5 centimeter aortic aneurysm for a man who is 5'10", or in a woman who is maybe just 5'2". It's the risk of rupture is much higher even at 5 centimeter compared to 5.5 centimeter.
And I think that's a very important point, because truth is there are algorithms and there are groups that have done research in normalizing or correcting the size of that aorta to the body size, because it's not the same thing to have a 5 centimeter aneurysm in a little petite woman than to have a 5 centimeter aneurysm in a really big guy. So it does make a difference, and it does make a difference in our decision to what to do with it. So generally speaking, a number of 5.5 centimeters indicates to a surgeon that they should do elective surgery on a patient. Can you please explain to me, Dr. Bagameri, what elective surgery means, and what other cutoffs do we have for other people?
The elective surgery means that usually we, after appropriate workup, the patient bring to the in the hospital, in the operating room, and we cut out the disease segment of the aorta, and we replace it with the so-called Dacron graft. It's a polyester Dacron graft. I think we have an example right on the table. That's what we use to replace the aorta. For the mentioned earlier, the certain in genetic syndromic or non-syndromic people who have predisposition, we know they have some kind of underlying genetic problem. The cutoff probably lower. In Marfan syndrome, sometimes we operate in 5 centimeter, or certain Lewis-Ditz even lower, 4.2 centimeter. And in families where we know that they have previous aortic dissection or aneurysm or bad complication from it, our threshold will be lower.
So we have different thresholds, as you can see, for different diseases. In general, it's 5.5 centimeters, but for example, for certain syndromic, like Marfan syndrome, is 5 centimeters. And I can tell you for bicuspid aortic valve, generally speaking, is also 5.5 centimeters unless you have risk factors. If you have risk factors, then we go down to 5 centimeters to offer surgery. And those risk factors for bicuspid aortic valve are a history, family history of having aortic dissection or acute complication, a history of coarctation of the aorta, a history of smoking, a history of uncontrolled blood pressure, and when the dilatation is mostly of the root. We consider those risk factors, and that lowers the threshold for operation for bicuspid aortic valve. But I want to ask Dr. Pochettino, what does watchful waiting mean?
So I think the issue ultimately is managing risk. If we had a zero risk operation, theoretically one could argue as soon as you identify an aneurysm, you should fix it, be done with it. And we sometimes as surgeons are pressured into that approach. The issue is that realistically we do not have a zero risk operation. So we have to balance the risk of what we do, the risk of the operation, with the risk of the disease, if you want to call it that way. And that balancing act has been one that has actually over time changed because of some progress that we have made as medical professionals and surgeons. When I trained over 20 years ago, at that time, given the risk of surgery that was the rule, 6 centimeters was the threshold that we used. As we got better at doing the operation and our risk of surgery has come down, we have now been able to offer surgery at an earlier time. And I think one of the issues that we were kind of implicitly talking about is that if the risk of the disease is higher, say for a Marfan, or for somebody that we know if we wait too long, we may miss the window and the patient may rupture or dissect, we're going to offer surgery earlier. If the risk of the disease, again, dissection, is low, we are going to wait.
Let me ask you something. What is the current risk, chance of dying of somebody who's going to have an elective operation to repair their thoracic aorta? And does it vary from place to place? And is the surgical expertise a key into that? Does it play into that? And does the experience of the center, of the medical center, have something to do with that as well?
Those are all good questions. And in a otherwise healthy individual who has no other cardiac disease, no other kidney problem, and so forth, the risk of an elective ascending aortic replacement should be in the order of 2%. What are the risks that we're talking about? We're talking about risk of dying and having a stroke. Because the structures that are nearby the aorta are the aortic arch, and we talked about that's where the vessels that go to the brain come from. And of course, the heart is right below that, and whether we need to address the valve or not, what we do does affect the heart. So those are the primary risks. Again, elective surgery in a healthy individual should be in the order of about 2%. Now, of course, if a patient is older, has some coronary disease, has some additional risk factors for surgery, that risk will go up. But elective surgery should be a relatively low risk, unlike emergency surgery, which is not, which is why, if at all possible, we want to get there before complications occur. And again, it's always a balancing act. You don't want to get in too early, but you don't want to miss the window and deal with it with a bad situation of a dissection.
Does the surgeon have to have particular expertise in this type of surgery, and what's the importance of the center that's doing it?
So as anything else that we do, the more you do of something, the more focused you are in that aspect of your practice, the better you're going to get. And there's nothing particularly different about aortic disease compared to, say, mitral disease or other issues that we deal with in the surgical world. So the answer to that is it makes sense that to have best results, you both as a surgeon as well as an institution should see that disease often. And it's because it's not just the surgeons that is involved in the treatment, but is the operating room, the cardiologist, the intensive care unit. There's all sort of team approach that makes a difference in terms of outcomes.
So I think it would be fair to say that if you have a thoracic aortic aneurysm that needs treatment, it is important that you look for centers that have high level of experience and that you look for surgeons that have specific expertise in repairing this type of problem so that you get the best outcome possible. Final question that I want to ask you is what is an acute aortic syndrome, which I suppose that is when you need to do emergent surgery, and what is the implication of this?
So acute aortic syndrome is basically a constellation of emergency condition with the same clinical characteristics. Usually people presenting with severe chest pain, back pain. It can involve, most commonly, the most well-known is aortic dissection. Basically, it's a tear of the aorta, has 3 layers, and then the layers are separating. It's a life-threatening complication. You need immediate medical treatment and surgery. The chance of dying from it is 1 or 2% per hour in the first 48 hours, and we know that the medical treatment is not way inferior compared to surgery. The other could be intramural hematoma, basically, which is just bruising of the aortic wall. There is no true separation. Or sometimes you can have a penetrating aortic ulcer. Our goal is to prevent the aortic syndrome, to get to these people who are having either aortic aneurysm or have predisposition for dissection, to do this surgery electively before it gets emergency. Because as Dr. Pochettino alluded, the elective surgery, the risk of surgery around 2 to 5%, depending on what other medical problems you have. In emergency settings, the risk of dying, having or major stroke, gets up high as 15 to 20%.
So it's very important to identify an acute aortic syndrome early. And as it's usually described, it is described as a sensation that the patient has never felt before in the chest, typical tearing, sharp, very severe pain that goes from the front of the chest to the back, and that is how it's described. And I think that patients that have thoracic aortic aneurysms have to be a little bit attentive to that. I just want to touch on one point before we close because time is running out. And the point is this: what can a patient that has a thoracic aortic aneurysm do to prevent it from growing, from getting bigger, from incurring in aortic dissection and stuff like that?
I think we already alluded to the risk factors. The tight blood pressure control, have to go to the primary care doctors, and very high blood pressure, try to control. Also, the very important, the smoking cessation, to stop smoking. If they have overweight, try to lose weight. Active lifestyle, exercise, it's very important, the aerobic exercise, usually jogging, swimming, and try to avoid heavy weightlifting. It doesn't mean that they can lift up a couple pounds, but they should not go into the gym and try to bench pressing with 200 pounds. And ultimately, is that if they know that they have predisposition, then they should get early screening.
Yes. So I think that we are running out of time, and I want to thank everybody for joining us. In particular, our two surgeons who are fantastic on this great discussion we've had about thoracic aortic aneurysm. The discussion will be on Mayo Clinic's YouTube channel for future viewing. And if we didn't get a chance to answer your question, we will try to do so after the broadcast. I wish to thank you very much and wish you a great day.